Hello and good day, Level 3. Welcome to NCM 116, Module 3M, Care of Clients with Alterations in GI Elimination. Through this module, we will be able to learn more on the importance of having a good and healthy body, particularly our digestive and gastrointestinal tract functioning. Also, relevant and necessary information regarding certain conditions will be tackled for us to gain adequate knowledge, appropriate skills, and the right attitude towards the appropriate management for the promotion of health. Just relax, enjoy the discussion, and get ready to learn. This is Mr. Benedict Dwight Gilipitan, your facilitator for Module 3M. Focus points for this module. We will be discussing on the following medical conditions. First, intestinal obstruction, both small and large bowel obstruction. Second is hernia. Third, intussusception. Fourth, volvulus. Fifth, Ascaris bolus. Sixth, peritonitis. Seventh, paralytic ileus. Number 8, congenital aganglionic megacolon, or commonly known as the Hirschsprung disease. 9, imperforate anus. And lastly, hemorrhoids. For each condition, we will be learning its disease process, how to assess the signs and symptoms, how to diagnose, and also how to go through with its management medically, pharmacologically, and of course, our own nursing care. Intestinal obstruction. Intestinal obstruction is a general term describing a blockage within the intestinal tract. This blockage disrupts the normal flow, resulting to various elimination problems. This obstruction may be secondary to a mechanical or functional cause. First, an obstruction is caused mechanically if there is a problem with the anatomy of the intestine. In simpler terms, the physical feature of the intestine is causing the problem. On the other hand, functional obstruction is caused by the intestine's physiological feature. Physiology refers to the functioning of an organ. Examples are amyloidosis, muscular dystrophy, endocrine disorders, or neurologic disorders. Additional note, functional obstruction may be a result from an occurring mechanical obstruction. Intestinal obstruction can also be classified according to its degree of obstruction and severity. For degree of obstruction, we have partial and complete. For the severity, we can describe an obstruction as a severe problem when an entire region of the bowel is affected, a lumen is occluded, or the vascular supply to the other parts of the intestine is disrupted. Small and large bowel obstruction. How do we define them? Basically, both are types of bowel obstruction occurring in different locations. Small bowel obstruction, or SBO, occurs in the small intestine, while the large bowel obstruction, or LBO, occurs in the large intestine. Presenting to you a simplified comparison in terms of their onset, abdominal distension, frequency of vomiting, pain characteristic, bowel movement, and the level of dehydration. How to diagnose SBO? We have 4 possible exams: abdominal X-ray and CT scan. The purpose of both is to identify abnormal quantities of gas and fluid in the intestine. This is also ordered to check for any collapsed distal bowel. And we also have an electrolyte study and complete blood count may be ordered. Its purpose is to assess dehydration levels, loss of plasma volume, and possible infection. All diagnostic exams focus on confirming the diagnosis, identifying its etiology or the cause, and also determining the likelihood of strangulation. Medical and surgical management for SBO. An insertion of an NGT or nasogastric tube may be ordered to decompress the bowel. Through the NGT, fluids may be suctioned out to release and decrease bowel pressure. Monitoring of electrolytes and blood components is mandatory to prevent bowel ischemia. Administration of IV fluids is also likely done to attain fluid balance and also in preparation for a possible surgical operation. A surgical operation is not always indicated for clients with SBO. It will only depend on the cause of the obstruction. We have two possible operations. First is laparoscopy. Its main purpose is to visualize the internal features of the intestine. Second is a laparotomy. This procedure is only done if there's a need to remove an organ or structure causing the obstruction. And for the nursing management, it emphasizes on the importance of proper assessment and monitoring. Here are the nursing interventions for a non-surgical client. Maintaining the function of the NGT. NGT patency should always be checked. Assessing and measuring the NGT output. The kind of output may present an underlying condition. Proper monitoring of fluid and electrolyte balance to prevent ischemia. And lastly, regular monitoring of bowel sounds, pain assessment, and checking of flatus or stool passage, which may indicate status improvement. How to diagnose large bowel obstruction or LBO. An abdominal X-ray and CT scan may be ordered to identify colon distension and also to locate the actual site of the obstruction. It has the same purpose of the SBO earlier. Another exam would be through a flexible sigmoidoscopy. This procedure is considered to be a confirmatory exam. Take note, barium studies are contraindicated to diagnose large bowel obstruction. For what reason? The barium suspension used has a tendency to thicken when water is reabsorbed from the colon. When this happens, the thickening of barium may further cause a more severe obstruction. LBO medical management. We have the restoration of intravascular volume through IVF administration. IVF administration would also correct electrolyte abnormalities. NGT may also be used, same with SBO, to aspirate or suction fluids to decompress the bowel. And lastly, a procedure termed as colonoscopy may be done to untwist and decompress the bowel. For the surgical management, cecostomy is a surgical procedure wherein a cecal opening is done to provide an outlet to decompress gas and small amount of drainage or fluids from the large intestine. Another procedure termed as colectomy, it may be total or partial, a procedure to remove any part of the bowel which causes the obstruction. A colostomy may be necessary post-colectomy or right after colectomy to attach the remaining colon to the outside of the body. This may be temporary or even permanent. Lastly, would be through an ilioanal anastomosis. This procedure is done to remove the entirety of the large intestine. Ileoanal anastomosis is also termed as J-pouch surgery. This surgery allows the client to eliminate waste normally even without the large intestine. Nursing management for SBO earlier also applies for LBO. We need to focus on monitoring symptoms which may indicate complications, especially post-surgery. Providing emotional support and comfort is also vital. IVF administration to correct fluid and electrolyte imbalances. Health education is also necessary for clients, especially on the function of their GI tract post-surgery. And lastly, post-op care is very important through abdominal wound care to prevent iatrogenic infection. Moving on to the next condition, we have hernia. What is hernia? Hernia is described to be the weakening of an abdominal muscle wall. Due to its weakening, a segment of the colon or intestine and also other abdominal structures tend to protrude or bulge out. We have 5 types of hernia: indirect and direct inguinal hernia, femoral and umbilical hernia, and the incisional or ventral hernia. These different types are according to their site or location. A picture is provided to visualize the different types of hernia. Hernia may be also classified in terms of the ability of the hernial sac to be moved or reduced into its normal position. We have 3. First, irreducible hernia. From the term itself, this is a type of hernia wherein the contents of the sac have the ability to be placed back into the abdominal cavity simply with a gentle pressure. On the other hand, irreducible hernia, or the incarcerated type, the sac contents can't be reduced or placed back into the cavity. And lastly, a strangulated hernia. This type of hernia is a life-threatening condition. The hernial sac and its contents may cut down the blood supply to the bowel, resulting to ischemia. Symptoms of hernia. First, a presence of a lump or protrusion in the area. This lump or lesion may indicate a strangulated type of hernia. Sorry for the misspelled word on the presentation. That is strangulated. Abdominal distension, absence of bowel sounds, nausea, vomiting, pain, fever, and also tachycardia are the common manifestations of any kind of hernia. By the way, the best diagnostic procedure or exam to identify hernia is through a good and thorough physical assessment. For the non-surgical management, clients need to utilize a hernia belt, or also known as a truss. This is worn by the client like a belt to promote stability and keep the abdominal contents from further protrusion or bulging. Surgical management for hernia. Herniorrhaphy is considered the best surgical choice for hernia. The term herniorrhaphy simply means hernial repair. This is a procedure wherein an abdominal incision is done to access the hernia. The hernial sac and its contents are then placed back into the abdominal cavity. Another method of herniorrhaphy is the MIIHR procedure, or the minimally invasive inguinal hernia repair. This is a procedure particularly done for an inguinal type with the use of a laparoscope. In this procedure, instead of placing back manually the hernial sac to the abdominal cavity, a mesh patch or pad is placed on the inside of the abdominal wall to support and sustain the muscle wall integrity. Hernioplasty is another option for hernial surgical management. What's the difference between herniorrhaphy and hernioplasty? In herniorrhaphy, the defect is repaired by stitching local body tissues and placing it back to the abdominal cavity, while in hernioplasty, a remote tissue or synthetic material, like a mesh, is placed to cover the defect that caused the hernia. But then again, both are surgeries to repair a hernial defect. Nursing management. Again, same with the previous conditions, a good and thorough physical exam to assess and monitor the client's condition is very vital. For pre-operative interventions, instruct the client to abstain any intake in preparation for the surgery. For post-op interventions, encourage clients to gradually promote movement to facilitate voiding. Voiding is a good indication of structural patency of different organs. Next, instruct the clients to avoid coughing as it may increase the pressure over the affected organ. Third, educate the client to promote rest for a faster recovery process. Fourth, proper post-op wound assessment should be emphasized to prevent iatrogenic infection. Fifth, encourage deep breathing exercises to promote lung expansion and also to enhance proper oxygen circulation, especially to the cells. Numbers 6 and 7 primarily involves pain relief interventions and also to prevent swelling. Eighth, avoid straining and lifting for 1 to 2 weeks to prevent complications such as wound dehiscence. Dehiscence occurs when an incision or wound reopens internally or externally. And lastly, give importance to proper post-op wound care. Moving on to the next condition, we have intussusception. Intussusception is a bowel condition in which one part of the intestine slips into another part located below it. As shown in the picture, there's the process termed as telescoping. This telescoping action often blocks food or fluid from passing through. It may also cut off the blood supply to the part of the intestine that's affected. Intussusception is the most common cause of intestinal obstruction in children younger than 3 years old. The cause of most cases of intussusception in children is still unknown, and most cases of adult intussusception are the result of an underlying medical condition such as a tumor. The most common site for this condition is at the ileocecal valve. Signs and symptoms for intussusception. We have both the terms clinical and classical symptoms. When we say clinical manifestations, these refer to either objective or subjective data observed by a physician and when perceived by a client respectively. In simpler terms, the client's manifestations upon checkup. Clients may feel sudden onset of crampy abdominal pain, being the most common manifestation for any kind of bowel problem. Clients may also feel tired and lethargic due to the ongoing obstruction causing much pain. And on the other hand, the classical manifestations. These are data which aids the physician to have a good diagnosis of a client's condition. For intussusception, please take note of the classic triad symptoms. We have pain, palpable sausage-shaped abdominal mass, and the presence of recurrent jelly-like stools. The presence of this kind of stool highly suspects a client to have intussusception. The current jelly-like stool is considered a pathognomonic sign for this condition. Diagnostic exams for intussusception. First, we have barium enema. Barium enema is a type of X-ray exam that can detect changes or abnormalities in the large intestine. This procedure is also called a colon X-ray. This is also considered a definitive diagnostic exam for intussusception. Second would be an abdominal radiograph. Its purpose is to detect presence of air from a bowel perforation or hole. And lastly, a rectal exam may be ordered. Its purpose is to reveal any presence of mucus, blood, and also to check for any intussusception in the lower part of the bowel. Medical management. Barium enema is not only used as a diagnostic exam, but also a form of medical management for intussusception. Its main purpose is to reposition the displaced or telescoped bowel into its original placement. If the barium enema is already successful, no further treatment may be required. Surgical management. If the intestine is torn and if an enema is unsuccessful in correcting the problem, or if a lead point is the cause, surgery is necessary. The surgeon will free the portion of the intestine that is trapped, clear the obstruction, and if necessary, remove any of the intestinal tissues that has died. This surgery is often named as initial reduction and surgical resection. We have another condition called volvulus. It comes from the Latin word volvere, which means to roll. In this condition, the bowel tends to twist and to turn on in itself, thus occluding the blood supply. Volvulus commonly occurs at the sigmoid colon. The most common cause for this condition is the malrotation of the intestine during embryonic development. We have three common types of volvulus. These types are based on their site or location. First type, the most common, would be the sigmoid volvulus. It may occur from pregnancy due to malrotation during embryonic development, and for middle-aged and elderly due to chronic constipation. Second would be a cecal volvulus. Its site is at the cecum. This is common in young adults. It may also be due to the abnormal development of the mesentery. And third would be the midgut volvulus. This is very common for babies and small children. The most common cause would be the abnormal intestinal fetal development. Here are the common signs and symptoms for volvulus. Clients may experience intermittent vomiting, recurrent abdominal pain and distension, and also may experience lower GI tract bleeding. The mesenteric twisting can only be seen after a diagnostic procedure. Diagnostic exams. First would be an upper GI series through a barium swallow exam. This is considered to be the definitive diagnostic exam for infants. For adults, an abdominal X-ray and barium enema may be ordered to confirm the diagnosis of volvulus. Please take note of the results for each exam. For X-ray, it will show a coffee bean image, while in a barium enema, it will show a bird's beak shape. Please refer to the picture shown. Non-surgical management. We have sigmoidoscopy and colonoscopy. For sigmoidoscopy, It is preferred for treatment of a sigmoid volvulus. Its purpose is to manually untwist and decompress the colon for pressure relief through the use of a sigmoidoscope. And to resolve cecal volvulus, a colonoscopy may be ordered. It has the same purpose of untwisting and decompressing the colon. For surgical management, an open laparotomy may be done primarily to untwist the colon and also to resection the bowel. This surgical procedure is only indicated if the volvulus already hinders the blood supply and affects a greater portion of the bowel. Ascaris bolus. The causative agent for this condition is Ascaris lumbricoides, the same agent which causes ascariasis. These parasitic worms can occasionally cause intestinal blockage when large numbers get tangled into a bolus or they may migrate from the small intestine. Signs and symptoms. We have two phases in which signs and symptoms are experienced by the clients. For the early phase, clients may be asymptomatic for the first few days. Symptoms such as non-productive cough, dyspnea, wheezing, and fever are very common 4 to 16 days after ingestion of the Ascaris lumbricoides. During the late phase, usually 6 to 8 weeks after the ingestion of egg, clients may already experience gastrointestinal symptoms such as epigastric pain, nausea, vomiting, a pharyngeal globus characterized by tingling throat, and also frequent throat clearing. Diagnostic exams. First, we have a complete blood count. A CBC may show an increase in eosinophils, which is very supportive of an ongoing parasitic infection. Second would be a sputum analysis. Its purpose is to reveal any presence of the charcot-laden crystals, which is also definitive for this type of parasitic infection. Third, a stool exam may be ordered. Take note, a stool exam result may be normal during the first 40 days of the infection. Its purpose is to check the presence of the causative agent, Ascaris lumbricoides. Radiographic exams such as chest X-ray and CT scan may also be done for clients suspected of Ascaris bolus. The main purpose of these exams is to reveal and visualize the presence of the parasite and also to check for the severity of the bowel obstruction. For the surgical management, an open surgery will be done to expose the bowel. Manual milking of the worms to the large intestine will be performed to manage the bowel obstruction. The surgery will only be indicated if the Ascaris bolus already impedes the normal flow of the GI system and if other non-surgical management are unsuccessful.